Yes, yes, please start.
So in total we have 1, 2, 3, 4, 5. I think only 6 people are there now, sir, as participants. Oh no, Samantha is showing. Okay, can I wait for 5 more minutes, sir, or I'll start, sir?
Please start because let other people join because it will take around 10:30 or so if we start late.
Yeah, okay. Makes sense, sir. Yeah, what is it? Correct, sir. Yeah. Very good evening, everybody. I'm Dr. Pranessh Ravi. For this segment, we'll be doing the anterior segment mock. I've tried to differentiate the questions as much as possible and speak about the core aspects and the concepts rather than identification, which is most commonly we ask in the exam. So as I told you last time, before answering these questions, before telling all this, please everyone take part in this mock because it will play a very vital role and it will help you perform better in the exam. You know your lacunae better, so this it's okay to make mistakes. Nobody will remember how you answered or how you performed after you pass the exam. So it's better to make mistakes here. Before you answer, take a brief pause for at least 3 seconds to consolidate and always start with the most to least common and prioritize answering the questions or the options, the points which you know the best first. So to start with, the first is, I've started the question with AGMs. So these are the 5 classes of AGMs which are being posted here. So I want to note the unwanted side effect and the key contraindications for these AGMs. Anybody want to answer this? We have Dr. Ramya, Ayala, Kimunu, then anybody wants to take this? We have 14 participants now. HP, Yasmin, Satish, sir, Nayana, Dr. Nayana. Anyone can answer this question.
I will start.
Yes, ma'am. Ma'am, it's okay. Any one point is sufficient. If you don't know also, it's fine.
Okay, prostaglandin analogs.
Yes, ma'am.
So the most common side effect is eyelash lengthening. There is hyperpigmentation of the lashes. Then it can also cause periorbital pigmentation. Then
periorbital pigmentation, yes.
Yeah, then it can cause increase in the uveitis. Then conjunctival hyperemia.
Yes.
Then atrophy of the periocular fat. Yeah.
I'm not sure about that, but okay.
And sometimes, and it can also aggravate the previous herpetic keratitis. Yeah.
Yeah, that is a contraindication. If you are dealing with
what?
orbital fat.
What did you tell? Or atrophy of?
Periocular fat atrophy.
Periocular fat.
It is not like periocular patch atrophy. Dermatoprost has been associated with something called prostaglandin orbitopathy, in which there may be deep superior sulcus. The atrophy of the periocular fat might be there, and there might be lead changes. So you can read about this thing, the features of prostaglandin orbitopathy, and please post on the group also. Okay, thank you.
Okay. Contraindication, yes, key contraindication is hepatic. So dealing with the trabeculitis in such scenario, then it would be not advisable to use a prostaglandin analog. And also in pregnancy, it's not advisable. For beta blockers, ma'am?
Beta blockers, main contraindications, side effects, ocular side effects will be
certain things are similar for every
allergy, ocular allergy.
Not that not that common. Yes. Anything else,
side effects, I'm not very sure.
Yes.
Then systemic side effects mainly cardiac side effect, cardiovascular diseases. Then bronchial asthma.
Contraindications, yes, for any, because they blockers will constrict the smooth muscles, so you would not want to use it in any patient who has got a respiratory illness, and also in cardiac patients, because it can delay the conduction. Yes, that is perfect. But what are the side effects that you can think of, ma'am? You see, told a similar thing in
Conjunctival hyperemia.
yes, yes. Anything else, ma'am, you can think of? It is something corneal.
Punctate keratitis.
Yes, perfect, ma'am. Alpha agonist, ma'am. One side effect, one contraindication.
Alpha agonist mainly allergic reaction.
Yeah, follicular conjunctivitis, perfect.
Yeah.
On contraindication.
Less than 5 years. Children
Perfect.
less than 5 years.
Why, ma'am?
Because it crosses the blood-brain barrier. So
Perfect. Yes. Carbonic anhydrase inhibitors, ma'am.
carbonic anhydrase inhibitors, the main adverse effects will be a bitter taste.
Okay, ma'am. Something with relation to cornea, ma'am. In certain scenarios, you would not want
Yeah,
to use this.
corneal edema.
Yes, fine. It will cause an endothelial pump dysfunction.
Yeah,
Perfect. Cholinergics, ma'am. And any unknown contraindication, ma'am, for carbonic anhydrase?
I'm not sure. I think output some cardiac.
It is
Sulfa
related to
allergy.
the drug is of a certain class, and that allergic patients are not.
Sulfonamide, that is.
Perfect. Yes, yes, correct. Super. Cholinergics, ma'am.
Cholinergics, mainly it can cause headache, retinal detachment.
Broache to be precise.
Broache.
Yes. Okay, ma'am.
Yeah.
Yeah, yeah. Retinal detachment, yes, yes. And any not there's no significant contraindications for this. I should have cancelled it out. Yeah, but side effects, that much is sufficient. Now this for the second question. Can I have any takers for this? There are in total 19 participants. Anybody can take. Please answer these questions. Dr. Temina ma'am, Satish sir, Nayana, Dr. Nayana, Dr. Aparna, Ashwati. Anybody can take this.
Right.
Can you please, sir?
Aparna, please, yes, madam. Please, ma'am. Explain. Describe the photograph and tell your findings.
This background picture of probably left eye showing a post-operative case of iris coloboma, and there is.
How did you say it is post-operative, madam?
I think that is a PCIOL there.
Yes.
So I can see the posterior chamber IOL with anterior capsular fibrosis.
Okay, what would you call that as? No, actually, it's better to go from anterior to posterior. You told this is a external anterior segment photograph of the eye, and you can talk about the lid's surface and then cornea, then go backward. That would be the way to
The
handle
lid
this
margin
question.
is looking normal. There is
Okay.
mild conjunctival hyperemia.
Perfect.
And there is an early limbal deficiency I can see at 3 o'clock. Cornea is clear. Anterior chamber depth appears normal, and it appears quiet on gross examination.
Don't comment on anterior chamber depth, ma'am. You can't see that on a photograph.
All right.
Okay, so do not comment on that.
Okay.
Yes.
So
What
then,
are you could IOL you've spoken of? What is the thing that you're seeing a coloboma? Okay.
yeah, there's a coloboma, and
Okay.
it is a typical coloboma at 6 o'clock.
Okay. What is the common location of coloboma, ma'am?
It is the inferior location. Because
Anything in specific to laterality, inferior nasal, or inferior temporal?
Because the optical fissure closes at that area, so the coloboma is most common at in the 6 o'clock position. It's
Are you sure?
it's 5 o'clock or 7. I'm not sure about that.
Inferior dash, there is a position. Nasal or was it nasal or temporal?
Inferior nasal.
Fine, good. Okay, you see the cataract being done here. So if you have such a scenario, then what are the things that you would look at in a case like this?
So in the case of coloboma, it could be associated with a lenticular coloboma. So I would look for the zonular deficiency. How many clock hours of zonular deficiency are there?
If you're having a zonular deficiency, for how many clock hours would you choose a CTR, beyond which you choose a CTS?
For
What,
3
how?
or less clock hours, we can use
Yes.
CTR.
Mhm.
And if it is more than that, then the ring segment,
Yes, perfect.
right?
If it's more than that,
So I would also look for fundus examination, thorough fundus examination before surgery, because it could be
yeah,
associated
that
with
will, I'll go later. If it's more than that,
in the anterior segment,
yes.
angle gonioscopy.
No. You are talking about CTS. If it's more than 6 or 9 clock hours, what will be your plan of action?
Then we can go for lensectomy and scleral supported
Lensectomy, you cannot do it for a cataractus lens.
sorry, lens extraction. And if the support is not enough to support a posterior chamber IOL, then we can go for a scleral fixated or a glued IOL.
Perfect. Perfect. Okay. What is the classification which is used to differentiate the types of coloboma?
Sorry, I can't recall that right now.
Okay. It starts with I. Can anybody else answer?
IDA classification in which the coloboma, if it involves the optic disc, it is starting from superior to optic disc, it is class 1. If it is inferior to optic disc, it is class 2. And if it is involving the not involving the optic disc, it is 3, grade 3. And if it is isolated, it is 4 or 5. IDA classification.
There is one doctor from Chennai who was also given a classification for a coloboma. Can you name the doctor?
Lingam Gopal classification.
Yes, exactly. He is my teacher. So yeah. And as in SN, so sir has also classification. Great. I think you well read. So Idaman classification is difficult to remember, but coloboma is very important question, ma'am. You should know. So something in the fundus that you would want to see, how would the coloboma involvement in the posterior pole prognosticate your cataract?
So it can involve optic disc, or it can
Yes.
also involve choroid.
Yes.
So if it is involving macula, then of course the visual prognosis will be guarded.
Yes. Yeah,
If
that's
it is
it.
not involving the macula, then the visual prognosis will be good.
Yes. And now going to the next question. Any takers for this question? This photograph?
Can I take,
photograph?
sir? I can take.
Sir, Dr. Nayana.
Yeah. I can see Dr.
take, sir.
Naina speaking. Yes, in yeah, Naina, you can go. Sir, who's the other one? Dr. Zakaria?
It's me. Yes. Okay. Dr.
Yeah,
Nayana.
Dr. Naina can take,
Please.
sir. The next question
Yes.
you can take.
Okay.
Yes, Dr. Naina, you can.
This is a limited anterior segment color photograph showing clear cornea. The pupil is dilated. There is ectropia on UVA and hypopigmentation of the iris. And the lens capsule shows 2 rings, one in the mid periphery and one at the pupillary margin with white fibrillar material on the lens capsule. This is a case of pseudo exfoliation syndrome. Pseudo exfoliation.
Okay. And what is this thing that you're seeing in pseudo exfoliation? The photograph, there is a sign being elicited. What is it called?
I don't know, sir.
I think it's target sign. Do you know why this happens?
Because while we dilate the pupil, the iris margin will touch on the lens capsule where the fibrillar material is not there, and so the deposition will not happen there.
No, not dilate. Why the patient is not going to come for an examination every day, right? There's something else which is happening here. See, the concept is correct, but you see, as the patient does near work in the daytime, the pupil will be constricted, and as the patient goes to a mesopic or a scotopic environment that dilates, no. So it will kind of push away the fibrillary material. That's why you see a interval in between the central and the peripheral area, and it also kind of gives you an idea about the pupillary status also. Okay, so what are the considerations you would complications you would have in a patient who has a pseudoexfoliation?
In a patient of pseudoexfoliation, there will be corneal endothelial. There could be corneal endothelial dysfunction and fibrillary material deposition in the ankle, and poor pupillary dilatation and sonnular
Anything else
weakness.
in angle that you would see in this case?
There is an extra line of pigmentation in the ankle.
What do you call that as?
I cannot recall it right now, sir.
Starts with letter S. SAM.
Sampulously line.
Perfect. Yes. Okay. Why does the hyperpigmentation occur?
I don't know, sir.
Because the zonules are weak, so it kind of the lens moves forward, it rubs the pigments in the posterior pigment epithelium and it disperses. That's the reason why it occurs. Okay. And what are the corneal things that I'm not too sure about I don't think pseudoexfoliation got anything to do with dysfunction. But what are the other the fibrillary material can be seen at the posterior sticking to the endothelium. There is also something else you can see in the endothelium also. It starts with K.
Krukenberg sphincter?
Yeah. Anything else you can see in the anterior segment? There is some eaten appearance you can see.
More eaten appearance of the iris.
Yes. Yes. Anything else you would specifically see in this patients in an iris in the edge of the iris in the pupil, let's say pupil to be precise.
There will be white fibrillar atrophy of the sphincter pupillae.
Yes. Any complications? Or can we tell you two issues that you can preoperatively look in cases of pseudoexfoliation, and what are any two intraocular complications you will deal with such scenario?
Poor pupillary dilatation and sonnular dehiscence preoperatively.
Yes.
And during surgery also same thing, sir.
Yeah, perfect. And the bag itself is very weak. So if you're dealing with a harder cataracts, it's better to do a slow motion phacoemulsification because you don't want to cause too much of destruction of the zonules. And second thing is you can do when dialing the lens after hydrodissection, you can do a two-hand technique to slowly dial so that you don't strain the zonules that much. And in case of weakening, you can use a CTR. And yeah, in harder cataracts, you should be very very careful. And when doing cortex aspiration, also be very careful. If you catch the bag, the whole thing will come up. Then land up with the dialysis. Yes, Dr. Zakaria, is your question. Thank you, ma'am. Very, very nice answer. Thank you very much. Zakaria, this is yours for you. What do you see here?
It's a diffuse photo of anterior segment of a patient in which the most obvious sign is the anterior chamber is filled with blood, which is called the hyphemia. It is the hyphemia is more than half of the anterior chamber, and also it's associated with fibrosis, fibrotic membrane. Conjunctiva is injected, and there is not any significant discharge. I cannot see the lens.
Fine. Can you tell me what is the possible causative for this? And can you grade hyphema for me?
Sir, the most common cause is trauma, of course.
And what kind of trauma?
Blunt trauma, sir.
Perfect. Okay. Can you grade hyphema for me?
This is, sir, grade 3 to 4.
Grade 3 would be perfect. Okay. What do you call grade 4 as?
Sorry, sir.
What will you call grade 4 as?
It's a total hyphema.
Total hyphema. Perfect. Is there any other name for that?
For total hyphema,
yes,
I cannot recall, sir.
It starts with a number, and the second one it ends with ball.
Sorry, sir.
It starts with a number and the second word is a ball. Dash ball hyphema.
8 ball hemorrhage.
8 ball hemorrhage. Yes, correct.
8 ball.
Okay.
Yes, okay.
Yeah, fine. What is the most common thing? What is the most important thing that you're most worried about in a case of a hyphema? What is something which once it happens, it's not reversible, and that is what you'll preferably want to prevent in managing such a case? Can you name that? It is
Sir,
it's dash staining.
It's the corneal endothelial staining, and also glaucoma should be
Corneal endothelial staining. Okay.
yes.
Okay.
Yes.
Not endothelium doesn't stain. Fine. Okay. Okay. Fine. So can you tell me why it happens?
Because of the lysis of the erythrocytes, sir.
Okay. So what happens to the erythrocytes? Can you tell me how the staining happens? I know this is okay. Basically, what happens is this hyphema, no, it's hemoglobin will break into hemosiderin. So, sunlight exposure also will kind of propagate this, will fasten it, and then this hemosiderin becomes toxic, and it goes and sits inside the corneal tissue, both posterior stromal. So that's the reason why you land up with the corneal blood staining. And blood staining is there's nothing which it can do. Once it's stained, it'll appear like it's also differential for hypopin. It'll appear yellowish tinged. So you would want to prevent that. So at what stages of hyphema and intraocular pressure would you want you want to kind of drain the hyphema, and at how many days would draining the hyphema would be your ideal time?
Indication for the anterior chamber lavage, sir, you mean?
Yes.
Yes. Sir, the evident for the corneal staining is the indication for the anterior chamber lavage, and also if the IOP is more than 50 for 2 days.
50 for 2 days, okay.
Yes, and if the IOP is more than 60, more than 24 hours. If it is more than 35, more than 24, more than 5 days. And sir, I can recall these indications now.
Okay, so if you're finding it very difficult to remember, it's mostly with regards to IOP, and at least in any of these aspects, just remember at least 2. Okay, how I used to remember is I'll take a week and multiply the week by 5. 7 5s are 35. So IOP, if it's still more than 35 for 7 days, and I used to remember only the 60 for 2 days. Okay,
for
if
2
this
days,
then
yes.
and yeah, and also if there is blood staining, yes, you can kind of evacuate the hyphema. Okay. Usually, if it's grade 1 or 2, you can leave. If it's grade 3, then it's better to evacuate. And what will be the set period time you would want to evacuate, or what will be the ideal time?
The ideal time is more than maybe 3 to 5 days. After 3 to 5 days, because
why is it that you need to give that time? Why is it that you need to give that time?
Rebleeding occurs, sir.
Yes, perfect. Yeah, perfect. Yeah, great. Next question. Any takers? Any takers?
So I'll take it.
Yes, ma'am, please.
Then,
Ma'am,
right.
please.
So yes, this is an anterior segment photograph.
Ma'am, I hope you understood the exercise, everybody. You can directly go to the diagnosis and whatever you see, and you can.
Okay. Right. So there appears to be actually I can see the opacification of the capsule, but I'm unable to judge whether it's in the interior portion of the capsule or the posterior.
It's not opacification.
Glistening of the iris, sir.
Oh, there's not glistening also.
This is
It's not opacification. You can see a slit section. You can see something behind the
yeah.
eye.
It's a mirroring.
There is haptic captured in the iris.
The IOL.
No.
This is
Haptic is in the
status
bag.
post
IOL is in the
Yag
bag only.
capsulotomy, no?
Probably.
With a capsular.
Capsular distension, sir?
fluid behind the lens
Yes.
in capsular
It's
bag.
CBS or CDS. Yes, perfect. Yeah, it is capsular blockade syndrome or capsular distension syndrome.
Okay.
Why does this occur?
So this occurs when there is entrapment of fluid between the capsular bag and the IOL.
What secretes the fluid?
The ciliary body.
Are you sure?
No, now I'm not.
Now you're not. Ciliary body, you've already the capsule is already zipped. No, you put the lens. Now the rexis is closed. It's zipped. So how can fluid form inside an enclosed space? Something which is inside only should form the fluid. No, what is there? What is
Yeah.
the
Epithelial cell liquefaction?
perfect liquefaction? Okay, secretion would be better. Yes. How do you manage this case? And what is the refractive outcome you would see in this scenario? What
So
surprise will you see? Will you see a
Myopic.
myopic or a hyperopic surprise?
Myopic shift.
Okay, why?
Why? Because there will be increased bending of the light because of the accumulated fluid behind the IOL.
Oh, the refractive index
And
is the same, no?
No.
How will the bending happen?
Because of the anterior displacement of the IOL.
Perfect, yes. May I know who said that?
Aparna.
Aparna, great, madam. Super, fantastic, yes. Yeah. So how would you treat this case?
we'll do a YAG laser posterior capsulotomy to release the fluid into the vitreous cavity.
Okay, fine. Is there anything else that you can do apart from this?
Can we use cycloplasm, sir, for this patient?
What?
Cycloplasm drop.
I don't get you, sir. What is it, sir?
Can we use midriotic for this patient, sir?
No, not required, sir. It's in the capsule. You have to release the enter of the fluid. Now, one thing is you can release it into the vitreous, or you can do something else.
Anterior capsular
Like
YAG can be done also, sir.
no, that is for anterior capsular phimosis.
Sir.
Here you can do a surgical thing also for this.
Anterior vitrectomy, sir? No.
Posterior, pars plana. Basically, what happens is usually the capsulotomy. But once what happened was there was a patient who had a capsular distension. This patient had a lot of fluid. Then this went into the vitreous, and he had a slight drop in vision. So we had to manage it with a vitrectomy and remove that area where the fluid had been extravasated. So if you see a well distended bag, it's always better to just kind of punch out the capsule and absorb the fluid through the posterior approach. Next question. Can you take us for this?
Yes, I can take this.
Yes, perfect. Doctor, yourself?
Dr. Mohammed Roman.
Perfect, sir. Please explain the photo and what is the diagnosis?
They're showing anterior segment photographs of I couldn't utter the right or left eye, but there is a diffuse ciliary congestion is there, and on the cornea around 8 o'clock position there is protrusion of the iris tissue through the corneal defect. Which is extend from 7 to 8 o'clock position, and there is a glistening membrane overlying the protruded cornea iris tissue was there. There was some whitish opacity around the margin of the protruded iris was there. AC anterior chamber, I couldn't say properly the depth of the anterior chamber, but it was irregular. It looks like irregular. Shallower, mildly shallower on the area of iris protrusion, but otherwise seems normal. Pupillary margin seems okay, and there was no any lenticular opacity. Lens was fine. So it's a case of iris prolapse through the maybe pre-existing wound or after trauma.
Okay, what would be your diagnosis?
Iris prolapse. Penetrating
Iris
corneal.
prolapse. What might be the causative for this?
It could be due to trauma, penetrating corneal injury.
Are you sure?
or it could be pre-existing thinning of the cornea and pre-existing thinning of the cornea due to corneal ulcer.
Anything associated with inflammation you can think of causing this problem? You can see the overall peribulbar congestion. It is more focal towards the area where the perforation has happened.
It could be marginal keratitis, perforated
What do you call
stage.
that as? It starts with P.
Peripheric ulcerative keratitis.
Perfect.
Peripheral
Okay.
ulcerative keratitis.
Okay. How do you differentiate peripheral ulcerative keratitis with Moran's?
In case of peripheral ulcerative keratitis, there will be limbitis as well as the associated episcleritis and scleritis. But in case of Moran's, there will be a clear area between the ulcer and the limbus, and there will be not any involvement of scleritis.
Okay, you are having a 2 to 3 mm perforation here. What will be your management in this case?
I didn't get it. Please
There's approximately 2 to 3 mm perforation here with iris plugging the perforation. Now, what are your management protocol here? How do you manage this case?
As it is more than 2 millimeter, so I'll go for either a scleral patch or amniotic membrane graft here.
You're having a full thickness perforation. Do you think amniotic membrane can hold this?
No, sir. I'll go for scleral patch or segmental or lamellar keratoplasty.
Lamellar you can't do. You have to do a full thickness. You have to take a biopsy punch. You have to punch out the cornea and you have to fill the defect only after the inflammation is inactive.
Right, sir.
Okay, but you glue 1 to 2 mm glue you can do. After doing an airfill you can do. And if you are suspecting, you can do recede the conjunctiva and you can apply glue for it to, for the perforation to scar out and then for it to fibrose and then stabilize. If you're having such a large perforation, this looks more or less inactive. But would start oral steroids, give topical cyclosporin, and then you can perform a patch graft. Lamellar you can't do. If it's only a lamellar defect, then doing lamellar makes sense. If it's a full thickness, melt and going full thickness is the way to go. Perfect, sir. Great answer.
So, sir, one question.
Yes,
So here the iris is out, no? So what about iris? We will reposit or abscess?
Usually, I'm just telling what my understanding. It's always better to, there will be little bit of a pseudocornea, like a fibrillary material over the iris. You just remove it and then assess how the iris is. But now, after all the procedure, we are putting intracameral moxifloxacin. So the abscission or excision of the iris is primarily due to not cause a secondary infection. But why do you want to distort anatomy? You are having intracameral, you're giving it. If you're able to maintain it, why do you want to distort it? So you just see how old the injury is. If the iris is it has been out for quite some time, it will become very pale and it will become very necrotic. You need not abscess it. That itself will slough off and it will come.
Okay.
So I've stopped doing that, but this is my understanding. I think you can, but I have not had any issues till now. I've handled a lot of trauma cases, so usually I just clear it out and put it in, give some intracameral moxie, and most of the cases are fine.
Okay, thank you, sir.
Thank you, ma'am.
Sorry, sir. So this defect will be covered with full thickness corneal graft?
Yes, ma'am. Yes. Immediately, if you have a piece of PUK, then the conjunctival recession with glue, you want to reinforce it. You want to put the patient on, inflammatory, anti-inflammatories like corticosteroids and oral with topical cyclosporin, things of that sort to curb the inflammation. And then if you're having a full thickness defect, you cannot leave it like that. This AC will collapse, the eye will go to hypotony. Then because of that hypotony, subsequent problems will happen. Then choroidal detachment will happen. That's the sequelae that's going to happen. So you don't want that to happen. Any leak, you don't want to close it as soon as possible. So circular patch graft would be the best option, full thickness. Only after the inflammation is controlled. Or you're on anti-inflammatory, then you can think of that option. Otherwise, the inflammation will further spread down to the patch graft, and the point of doing it only will get lost. Any takers for this?
Okay, I will go.
Yes. Diagnosis, what is the stages of this disease?
Diagnosis seems to be neovascularization of the iris.
Okay.
And what was the second part of the question?
What are the stages? There is a sequelae. There is
Okay.
yeah, there is a because of neoescalation of virus, something else can happen. What is that you look at this case?
The intraocular pressure for
Yes.
neovascular
What do you call
glaucoma.
that as neovascular?
Neovascular glaucoma.
Perfect. What are the stages of neovascular glaucoma?
Neovascular glaucoma can be open angle or narrow angle glaucoma.
Okay.
There can be
Open
a membrane blocking the trabecular meshwork, or later on there can be a synovial angle closure.
No, there are 4 stages.
Okay, I'm not aware.
So there are 4
Anybody else wants to
stages:
try?
P-rubeosis stage, rubeosis
Yes.
iridis, open
Yes.
angle glaucoma, and then angle closure glaucoma.
Perfect. Perfect. Great. Great.
Okay.
And what is the most common etiological cause for this neovascular glaucoma?
The most common causes would be proliferative diabetic retinopathy, central retinal vein occlusion,
Okay.
Central retinal artery occlusion,
Okay.
ocular ischemic syndrome.
Okay. And tumors.
And yeah.
In vein occlusions, which one would be the most common causative for this?
The ischemic central retinal vein occlusion.
Okay. And what would you look in this case? What findings will you see in the GONU? How would you manage this case based upon the visual potential?
So in the angle, we will look whether the angle has neovascularization and whether there are whether there's synovial closure. And the management would depend upon the visual potential. So if it is an eye with visual potential, we try and manage the primary problem, the retinal ischemia first. So we can give intravitreal anti-VEGF injections initially to reduce the.
No, let's stick pertaining to the diagnosis. So how would you manage this? Yeah, you'll treat the primary cause, perfect. Then how would you treat this diagnosis?
So
you got it sorted. Now you're left with the glaucoma part. How would you manage the glaucoma?
So the glaucoma part, usually the intraocular pressure will be quite high. So we might need to give systemic anti-glaucoma medications to reduce the.
Are you sure?
Because the topical may not
initially,
act
initially, okay,
initially,
fine, okay.
yes, yeah.
Okay, fine. Okay,
And
yes, sir.
yeah, so once the intraocular pressure is reduced systemically so that the topical anti-glaucoma medications can act, then we start the patient on topical anti-glaucoma medications also. Yeah. And along with that, and then we treat the primary, we try and treat the primary cause by giving pan-retinal photocoagulation with or without anti-VEGF injections initially, which might help in, because the pan-retinal photocoagulation would take some time to act. So meanwhile, anti-VEGF injections can act faster.
Usually injections are only given for if you're dealing with a macular edema. That's what my retina colleague told me. But usually there are literature, but usually we don't do that. If you have such a case scenario, then you will definitely be landing up with a much severe thing. So I think mostly PRP, DM control should be sufficient. If you are dealing with any branch retinal vein occlusion, then lasering of the ischemic retina would do the job. I think Kaushik sir can comment on this.
Yes, basically, if there is MVG, better tell that I find out the cause and I treat the cause, and more if it is ischemia, then I do PRP, pan-retinal photocoagulation. If the examiner asks you what are the other modalities, then you can tell about anti-VEGF. No, people have given the anti-VEGF for neovascular glaucoma also. You can directly give it to reduce the new vessels, and specifically they have given it before trabeculectomy for neovascular glaucoma. So that might reduce the intraoperative bleed also. But
intracameral also,
I'll
that
say intracameral, or you can give intravitreal also before this day. Basically, if you are giving intracameral, problem is sometimes if there is hypotonia, the new vessel will bleed. and there will be a total hypemia. So that is another difficult thing, because these new vessels are very fragile, and if you fluctuate the pressure too much, then there would be a difficult situation during surgery itself or during the intravitreal injection itself. So even if you inject intravitreally, the new vessels are usually regress by 1 day, 24 days only. But in theory, you better tell that I'll try to control, I'll try to find out the cause of the disease and then treat the disease, and then do if obviously there most likely will be this appendicitis ischemia, then I'll do PRP. Then if they ask that what are the other options, then you can tell that I can give anti-VEGF. And also in such eyes, you have to see the visual potential also. There might be such eye with no PL or no persistent light, or PL plus PL inaccurate, PL is blind eye. Then you might not do anything also. So in such NVG eyes, the vision of the eye is also one major thing. If there is visual potential, then only you will treat. If there is painful blind eye, you can directly go for diode laser cyclophotoablation or cyclocryo. If there is no malignancy after you rule out with ultrasound.
Thank you, sir.
Yes.
Always in this case scenarios, if you're preferring trab or tube, it's always better to go for tube, because trab, once it bleeds, the trab fails. Fibrin is a very bad enemy
Yes,
because it
yes,
causes a lot
yes,
of fibrosis. So if you always have option for a tube, it's better to go for a tube. If you can do a trab, then you can try. There are also reports which say we can do either. So this is just food for thought. Next candidate, can you tell me what is this that you're seeing here and when you would do this? Anybody, please?
It's the intraocular pressure
Phasing.
documentation.
Phasing, yes.
Phasing of
Phasing, Dano
intraocular
variation test.
pressure.
Yes. When would you do it?
Ocular hypertension.
No,
Are you
normal
sure?
tension glaucoma.
No.
Normal
Yes, normal
tension
tension
glaucoma.
glaucoma. What is the why are you doing it for a patient who's having normal tension glaucoma?
Because you want to rule out, you want to see if there are any intraocular pressure spikes, and the patient is actually not a normal tension glaucoma, but is having primary open
Okay,
angle
what
glaucoma.
inference are you going to get from these spikes?
That there is a periodic rise in intraocular pressure, which is contributing to the optic disc damage.
Perfect. Yes. Perfect. Yes. Okay. So yeah, there is this is called phasing. You have a in hospital OP phasing, and then you have a 24-hour. If you're not able to find any spikes in office, then you're still feeling that the damage is still happening, then you can do a 24-hour phasing. So you can exactly know when the damage is happening. So usually, when does the pressure usually rise?
Early in the morning.
Perfect. Yes. Yes, you're right. Great. Next candidate. Next question. Any takers for this? What do you see here? What is this photograph?
There I can see optic disc photo of the right eye, and I can see the optic disc. There is cupping, nasal shifting,
Yeah. No,
mostly
just 1 second.
glaucomatous.
This is the first fundus photograph. So can you
Fundus photograph.
explain how would you start with this photograph? How do you explain a fundus photograph?
Okay. This is
Yes.
a fundus photograph of the posterior segment of the right eye.
Yes.
First,
Okay,
a comment
perfect.
on the disc. The disc is well defined, but there is a cupping like
No, you forgot one
0.8.
main important thing. You should comment on that, and then you can go to the disc.
I was planning to start the disc, then blood vessels, then macula.
No. Before seeing, there is something in
Media.
perfect. Before in between the lens and the posterior pole, there's something. It's called vitreous. So you can say the wit cavity appears to be clear.
Media.
Yes, it's
Media
clear.
is
Media.
clear,
Yeah,
so
media is clear. Yes, yes. Then you can start on the
okay.
disc. Yes. You can go ahead.
So
Media appears to be clear.
the optic media is clear, vitreous clear. So optic disc then it's well defined, but there is a cupping like 0.8, and there is nasal shifting of blood vessels and pioneating of the blood vessels superiorly, and this prominent pallor, and the blood vessels looks normal, macula looks normal, and mostly glaucomatous optic atrophy.
What atrophy, madam?
Glaucomatous optic atrophy.
Are you sure this is glaucomatous optic atrophy? how does NRR appear? You didn't comment on NRR. That's what I wanted to come next. Does it appear
Okay,
healthy? There is a rule in glaucoma which it is violated here. Can you mention the rule?
It's not role.
Yeah, yes. Isn't rule is violated here. How is NRR
Yes, sir. Yes.
appearing?
Maybe it's pallor
Yes.
or this pallor.
Yeah. That is an important thing, no? Once you have pallor, then you call it as atrophy. If it's a
Okay.
pale disc, then it's more suggestive of it. The microvasculature is lost. That's why the tissue becomes atrophic. Okay. So what would
Okay,
you call these
so
cases?
it's neuro case.
Yeah. What is your
like
final diagnosis for this case?
secondary optic atrophy or primary optic atrophy. I don't know. I will just comment that
Glaucomatous
there is
optic disc.
Hmm?
Glaucomatous optic disc damage.
Glaucomatous.
Yes, that would be your final diagnosis. You just have a fundus photograph to.
Sir,
Yes. Hello.
sir,
Yes.
do we have to ask for the IOP to say it has glaucomatous optic nerve damage?
You can. Yes, you can. Yeah, you should ask the IOP. Yeah, it's better to ask for the IOP to tell if the patient is having glaucomatous. But I
And to
just
check
took
the other eye.
Yes.
And to check the other eye also.
Yeah. Yes. Perfect. Yes. They would want to like actually the lamellar dots and all were there. I don't know why while getting the photograph I'm not able to visualize that how deep the cupping is, the lamellar dots and everything you can comment and then you can suggestively tell that it's a glaucomatous disc damage. So for the next, any takers for this? This is a patient who had come. He had applied some drops. He's having this scenario. Can you mention what drops he had appeared? He had applied. He's using this drops for a certain issue with his eye. What drop? What is it that you're seeing here? How do you manage this? Any
Eye
takers?
drop?
11. Yeah, eye drops. Yes.
So
I can
I
take,
thought,
sir, the case.
Yes, please. Yes.
okay.
Yeah, sir, this patient may be using anti-glaucomatous drug, especially alpha agonists.
Okay.
And there is follicular conjunctivitis, which is the
Perfect.
side effect of that medication.
Yes.
It's especially inferiorly located.
Perfect.
There is a punctate epithelial erosion.
What is the name of the drug? How do you treat this?
It's brimonidine, sir.
Perfect. Yes.
Yes.
Why is apraclonidine not used
Sorry,
as
sir?
AGM? Why is apraclonidine not used as an AGM? Why is only brimonidine used?
Why apraclonidine is not used? Just
And how do you manage this? Can anybody answer? Why is apraclonidine not
sir,
used?
with management, I would first I would discontinue the medication.
Perfect.
And I would put the patient on the artificial eye drops.
Lubricants. Yes.
Lubricants, yes, both in drops and gel forms. And of course, if it doesn't, if it's inadequate, I would start some low potent steroids as well.
Yeah, it's perfect. Apraclonidine is not used because of tachyphylaxis.
Okay.
It is only used to decongest in minor procedures. Brimonidine, that's why it's commonly used. 12th question. Any takers? I have given the. I have just hidden the
Sorry,
important.
sir.
Yes, ma'am.
Why is apraclonidine not used?
Tachyphylaxis. Tachyphylaxis. That's the reason. Yeah, you can use it to decongest the surface if you're doing a minor procedure, and you can also cause minimal pupillary constriction. You can use, but it's most. That's the reason.
Horner syndrome. For Horner syndrome, we can use it.
Yes. But if night driving, if you have a procedure or a lens being put and you have a problem, you can use apraclonidine to constrict the people. So, but usually it's not commonly used as an AGM. That's the reason.
Yes.
This I have for angle closure. I have hidden out the important details. Can anybody classify angle closure based on anatomical classification And can you just mention the details of all the three stages of angle closure?
Can I try?
Yes, please, ma'am, please be my guest, please.
Okay. The staging, it can be primary angle closure suspect, primary angle
Yes.
closure, or primary angle closure glaucoma.
Perfect.
Okay. In primary angle closure suspect, there is up to 270 degrees of iodotrabecular contact, but there is no.
Are you sure it's 270?
More than 180?
180.
Perfect. Yes.
More than 180. Okay.
Yes.
Okay. So there
AO
is.
says 180. I told 180 in the exam. You can also stick with 180. I follow with 180. So.
Okay. Thank
270, more than 270, you're left with only one quadrant, no?
Up to 270. I mean, okay, more than 180.
Yeah, we have left to one functioning quadrant, right? So 180 is a safer bet. Yes.
Okay.
Yeah, please go ahead. And after this, you should tell me about ZAP trial also. That is also very important, not for the exam, but for day-to-day practice.
Okay. So in primary angle closure suspect, there is more than 180 degrees of iodotrabecular contact, but there is no peripheral anterior synechiae, no increased IOP, then fundus and field is normal.
Perfect.
In primary angle closure, there is greater than 180 degrees of iodotrabecular contact.
No, there's one thing which is adding there. In primary angle closure, one thing is adding.
Yeah.
What is it? There is a rise.
Rise in IOP may or may not be. The angles are suspicious.
There will be normal IOP. There will be normal IOP of optics.
Are you sure?
Yeah, the angles look suspicious, but everything else is normal, right?
There'll be disc changes or elevated IOP, but visual fields, everything will be normal.
Okay.
In primary angle closure glaucoma, simple. For glaucoma to happen, you should have a field defect. That should be some visual issue.
Yeah.
Only then you can brandish it as glaucoma, correct? So primary angle closure PACG will have a field defect. Angle closure will have elevated IOP or disc changes, but suspected disc of glaucoma. But everything else, you will have a collapsed angle, but everything else will be normal. That's how you differentiate between these three. Can you tell me something about ZAP trial and its importance in primary angle closure, primary angle suspect?
Yes, ZAP trial was whether or not PI should be done. In case of primary angle closure suspects, they found out that
what
there
are
was
the
there was no much benefit in doing PI because there was only I don't remember the percentage, but a very low percentage of conversion of primary angle closure suspects to primary angle closures. So we have to be. It's not necessary that you have to do a PI in all primary angle closure suspects.
For whom should you do it?
In those with increased IOP or
no.
PA.
Yeah, those who increase IOP, yes. But there is a specific people who should undergo PI.
I'm not sure.
If patients require repeated dilatation, if they have had diagnosed case of primary angle closure glaucoma in the other eye, and if the patient is a diabetic, in all those case scenarios, you can do a PI.
Okay.
Or else it is usually not required. That's what in the inference from ZAP trial you can get. Okay. Thank you very much. Next is this OSTS important studies. I've just taken this one. Rest all you can go through the values. What do you know about this? I have marked off the important points in the study. And what is the probability of developing glaucoma? That is what is most important. So any takers for this? Any takers?
Actually, I've forgotten. I've tried to memorize it so many times, but I'll try. Showed that topical therapy delayed the onset of glaucoma in ocular hypertension.
Okay. No, I'll just ask you. This is the randomized control trial. Okay. What is the pressure threshold which was set for this target IOP, and what is the probability of developing glaucoma? Just do this. You can tell, and that's it. We'll close it.
Probability was 9% versus 4%.
It was 24.
Oh, okay.
Plus 24. And
Okay.
probability of developing glaucoma, 4.4 and 9.9.
4.4, 9.9.
Yeah, that it was actual approximate halving of the people who develop glaucoma. So that's
Right.
what OHTS tells. Yes. This and on a CNT GTS also is very important, and you should know that also. At least the crux of the at least what is the conclusion, at least in words you should know. And all the other
Of what? Which trial?
collaborative normal tension glaucoma treatment study.
Right.
Okay. Yeah. So next taker, there's a set of questions. So can you just tell 1 point for all these questions which are being pasted here?
I can
Any
take
takers?
the first
Yes,
one.
please. Yes.
What are the common causes of blood failure, and
Yes.
what are the early signs associated with in blood failure? It will be hypotony or low IOB with shallow EC. That could be due to and the bleb will be flat. That could be due to conjunctival or wound leak. That will be with a positive T-bill test.
I'm
Or
asking. Okay. The bleb is not functioning. It's not filtering the aqueous. So what will be the causes for blood failure?
Something like there is a blockage, internal blockage with blood or any material or fibrosis or encapsulation, something like this.
Fibrosis, yes.
Due to
Anything
use
else?
of maybe mitomycin.
Okay. Anything else?
Blood failure can be because of inflamed eye,
Perfect. Yes.
neovascular
Perfect. Yeah.
glaucoma.
Perfect. Yes. Yes.
Blebitis?
No.
Not blebitis.
Yes, but looking for something else.
Bleb leak.
No. Okay, fine. What are the early signs associated with it?
Vascularization of the
glaucoma
bleb, sir.
also bleb can be failed.
Yeah, vascularization is bleb failure. Yes.
Yes.
How can a surgical technique contribute to bleb failure? Is a particular type of flap cause bleb failure?
Yeah.
Cornix base.
Using of some antimetabolites, sir.
Using or not using?
Not using, sir. Not using of some antimetabolites like mitomycin C or 5-phosphoryl.
Okay. And based upon the flap, cornix or limbal?
Cornix
Sorry,
base.
sir.
Yes.
Limbal based.
Yes. Yes. Pitfalls in flap construction.
Yeah.
If you have a shelving flap, it will most more commonly fail. And if the bleb has failed, how do you know that the bleb has failed? What are the signs to say the bleb has failed? And how to know if the bleb is functioning?
Bleb is failed, the IOP may be high even still after the trabeculectomy.
Okay.
And there might be flattening of the bleb or fibrosis can be seen.
Fibrosis, okay. Hyperemia will be there. You can develop a
Hyperemia will be
stenone
there.
cyst.
Yeah.
Gonioscopy, you can use a formula or you can use a cotton bud applicator, also put pressure on the opposite side of the bleb and see if the filtrate is going through the bleb. That's how you can assess its patency.
Okay.
And that's how you can check bleb formation also. Now, question number 15, any takers for this?
I can take, sir.
Yes. Axenfeld syndrome, Rieger.
Yes.
Can you just tell me the whole thing? I have just blocked out all the important things. So
Axenfeld-Rieger syndrome is a syndrome, sir, which is characterized by anterior segment dyskinesis and angle abnormalities. It's features of posterior ambiorexton and iris strength, anterior displaced of the Schwab line.
Yes.
Yes. Rigors involves iris abnormalities like iris atrophia, iris atrophia, and also
there is -topia, -chorea.
Polychoria.
Perfect.
And atrophia, sir.
Correctopia.
Perfect.
Correct.
Yes. Systemic findings?
Systemic findings such as
you can tell those ones which are mostly, you can tell one things in the face.
It's a defect, sir.
Yes. You can tell only those in the face. Something with
dental abnormalities.
Perfect. Yes. Perfect. Dental. Yes.
Dental
yes.
defect.
And one defect will be common with golden hair also.
Yes,
it's hypoplasia.
Hair,
What
sir.
hypoplasia?
Malar hypoplasia.
Malar.
Maxillary hypoplasia.
Maxillary. Yeah, perfect.
Yes.
And something inside the brain also. It's a very small gland. That gland also will be involved. Can you?
Pineal.
Pineal. Something similar lines. Starts with P.
Pituitary? No.
Yeah,
Pituitary.
perfect. So what is ARS? Axon-Filter syndrome?
Ragus anomaly and Axenfeld syndrome.
Yeah, both together is called as Axenfeld-Rieger syndrome. This is also an important question which I asked for the exam. Axenfeld anomaly will only have an embryotoxon and it will have the iris strands attached to it. Rieger will cause abnormalities. These both together are called as Axenfeld-Rieger syndrome. Perfect. 16th one. Any takers? What do you see here? What is done here? Some procedure has been done. It's 2 days after the procedure. So any takers for this?
Is it the corneal serum, sir?
Is it?
It's a. Shall I take? It's a penetrating keratoplasty.
Perfect. Yes.
Is it corneal?
Penetrating keratoplasty, yes. Anything in the iris that you're seeing? Can you tell?
In the iris there appears to be iris atrophy.
Perfect.
And
what is a fixed dilated
maybe
pupil post keratoplasty called as? What syndrome is it called as? Perfect. Yes. Uretzavalia. Perfect. Okay.
Dilatation of the pupil.
Yes, correct. Yes. So there are some marks you see in the conjunctiva. Why do you think that marks have occurred? How have they occurred? And why have they done it for this case? And based upon the sutures, how old is this case? And what is your final diagnosis?
Those marks are probably the cyclocryo marks.
Are you sure cyclocryo? Do they use cyclocryo now?
Diode photocoagulation.
Okay, good.
Okay.
Yes, it's cyclodiode. Yes. And what is the diagnosis for this case?
So the diagnosis is post keratoplasty glaucoma.
Yes.
Yeah. And
yes. Why did this glaucoma occur? What is a common thing which can cause this glaucoma? Uveitis part, one part, something with relation to graft sizing. That's
yes.
It's also the reason why you oversize the graft.
Yeah, the larger graft can cause peripheral anterior synechiae. And
are you sure it's larger?
Smaller graft.
I'm not sure.
Perfect. Yes. What will happen if you take a smaller graft and you encompass a large eye with a smaller graft? What will happen to the angle?
Angle crowding.
Perfect. Yes. That's the reason why glaucoma happens. Yeah. So this is a case of a post keratoplastic glaucoma. The idea of taking this picture is I want you to be vigilant about even the peripheral parts. That's why I took this. The exam will have bad pictures, so you should be have a look around at everything. And you just keep on talking, keep on explaining. Yeah, what is 17? Question 17. Any takers?
Blood infection.
Perfect.
Hypopine.
Okay. There's something else you can see here. Hypopine. So
Hypopine.
what is a common if there is vitreal involvement, what is it called as?
Blebitis.
Blood
No,
and
what is it called as?
ophthalmitis.
Blood vessel
Blood-related.
shutter and ophthalmitis.
Blood
Okay.
related.
What is this appearance is called as white on red appearance, classical of blebitis. How do you treat this?
I'm not sure, sir. Intensive antibiotic therapy, intravitreal
Blebitis is
antibiotics.
important topic. Come on, anybody help us, please. It's very simple, no? You need not, it's not in the vitreal space. So you not inject anything. Your topicals will definitely penetrate to this area. So how will you treat this?
Okay, fortified.
You're landing, you're having an acute infection. You cannot give a broad spectrum antibiotic or moxi or Ciplox. So you want to go for a more specified tailor-made approach or a fortified approach. So how will you treat this? You want to cover all steps. It's a bacterial infection. You want to cover gram-positive and gram-negative. So how will you treat this?
Okay, I'll start the patient on hourly fortified cefuroxime and fortified amikacin, sir.
Why
Fortified
cefuroxime and why amikacin?
Cefuroxime for gram-positive organism and amikacin for gram-negative.
Yeah, but they are more higher in the scale. No, there is something called. Your thing is correct, but cefuroxime, there is something which starts, which has a letter Z in between. That is usually taken.
Ceftazidime and
Cefazolin,
vancomycin.
no, first
Cefazolin,
cefazolin, then you can superseded with vancomycin. You can first start the patient on tobramycin and then gentamicin, amikacin. That's the step ladder approach as far as gram-negative, gram-positive and gram-negative bacterial coverage is concerned. But yeah, fine. What the concept is perfect, okay? And for blood-associated endophthalmitis, you just treat it as how you treat a case of endophthalmitis. Yes, there is anterior segment inflammation, which is
So
exhibited by the hypo.
The gram positive will start with the cefazolin or vancomycin. No?
Yeah, cefazolin is the first defense, first line. Then you would go superseded with vancomycin.
Okay.
Okay. Question 18. Any takers? What are the type of lenses that you see here? Which lenses need coupling fluid? Which lenses don't need coupling fluid? One specific lens can see three varied parts of the anterior, and the posterior segment. What lens is it? And what are the other uses of using a 4-mirror gonioscope? Tell me two names of a 4-mirror gonio.
Sussman lens.
Perfect. Another one starts with P.
Bosnian.
There is also one which starts with Z.
Zeiss.
Perfect. What are the parts that you can see with a 3-mirror lens? Can you tell me all the angles for these lenses?
Goldman 4-mirror lens.
Ma'am?
No,
the angles, if anybody can try.
On the B picture, sir, on the B picture B, there is a Goldman 3-mirror gonio lens is there, and through the central round part, we can see the posterior pole, and there are 3 mirrors in the periphery. Yes. One mirror is oval in shape, which we see.
No, what are the parts that you can see? And if you tell the angles, I'll give you a treat.
From the central mirror, we can see the posterior.
There are 3 mirrors. One is trapezoid shape. Another is oval shape, and another I couldn't mention. Through the oval shape, we can see the angle, anterochamber angle, and by the trapezoid shape, we can see up to ora serrata, from pars plana to ora serrata, and the third one, which shape I didn't recall, we can
something in between above the ora.
Era to posterior pole to era. Ora.
No, something which is above the ora. Fine.
I couldn't
tell me the
recall,
angles?
No, angles of the mirror.
Yeah, what are the angles of the 3 mirror and the angles of the single mirror?
Oh, I
No,
couldn't.
not the 4 mirror, the 4 mirror, sorry. They are all in a stable angle. 4 mirrors are all in a stable angle. The 3 mirror differs.
In case of 3 mirror, I couldn't answer. Sorry.
There is 159.
Right, 5,
and
6, and 7. Okay. Right, 5, 6, and 7.
59, 67, and 70.
Perfect. Yes, yeah, exactly. Yeah, you're right. 59, 67, and 73. Yeah, simple. And the 4 mirror is always static at 64.
Can you repeat it? Can you repeat it, sir, slowly?
Right, 5, 6, and 7. And for start with 9 and keep on decreasing. 5, 6, 7, 9, 7, and 3. That's it. 59, 67. That's the easiest to remember. And for 4 mirror, it's 64. And for 4 mirror, you don't require a coupling. The tier will act like a coupler. And for 3 mirror and 2 mirror, you require a coupling fluid. For 4 mirror, you can do indentation gonioscopy. But for 2 mirror and 3 mirror, 2 mirror, you can single mirror, you can only do manipulative gonioscopy. You cannot do an indentation gonioscopy. And for 4 mirror, it will always come with or without a handle. 2 mirror or 3 mirror will usually not have any handles. And for Goldman or 3 mirror lens, it's good for laser procedures, but that cannot be done in case of a 4 mirror lens. And question 19, any takers? What do you see here? Tell me all the problematic things in this field, and what is your final diagnosis? What is the diagnosis of the field report? Come on, fast. I have a few more questions. Yes, please.
Well, I can take it.
Please, sir.
This is a printed copy of harmful visual field analysis of 24-2 threshold test, which shows the reliable indices are within the normal limit. There was no significant fixation loss, false positive or false negative errors. Test was done by stimulus size 3, white light, background 31.5 F strip light, and CETA standard protocol. There was showing on numerical raw data, there was diffuse generalized reduction of the sensitivity in all over the visual field, which we can also see in the total deviation. There is a marked deviation, which also similar to the raw data. And in case of grayscale data, there is a blackish area, which is reduced sensitivity area in whole of the superior, inferior in visual field, which except some central area which have some sensitivity. And there is a total deviation numerical plot. There is also significant decrease of sensitivity below the p-value. And there is no pattern deviation plot here, and glaucoma Hemphill test was outside normal limit, and visual field index was 24%, and mean deviation was 24, which is very severe, and PSD value is 10.03 decibel. So my diagnosis say, I want to see the other eye visual field also to diagnose, but it's a case of advanced glaucomatous damage.
Okay, you're having a biaquate scotoma. Okay, you would want to do anything else after this? You've done a 24-2. You would want to do
yes, sir. I want to do the macular protocol or 10-2 protocol here.
Perfect. You want to see the central vision? Yeah.
And also the macular sparing, yes or not?
Perfect. Yes. Perfect. Everything is right. You just know your indices. What will be the accepted gram? False positive, false negative, and fixation losses?
Yes, sir. In case of standard test, we will accept anything less than false positive or false negative error 30%. But in otherwise cases, 20% of the false positive and negative cases are also better to accept it. And fixation loss, 30% fixation loss.
30 or 20?
So I'm confused. 33.
Fixation loss 20 and false positive, false negative 33.
33, yes.
Thank you, sir.
Fixation is central and visual field index is reduced. This is a case of a severe glaucoma showing biacute scotoma. Perfect, yes. What do you see here? 20. Any takers?
There is this anterior segment photograph. There is a pinkish, pinkish, yellowish pink mass on the temporal aspect of the right eye.
Okay.
Not reaching the limbus.
Okay.
So this could be a case of dermalipoma.
Okay. How do you differentiate between dermalipoma and fat prolapse, orbital fat prolapse?
There is a sharp anterior border. And
Okay.
you can see the structures like a hair keratinization on the surface.
No, there are no structures here, ma'am, actually.
Okay.
This is better, yeah. So,
Yeah, demonstrate. And fat prolapse is usually bilateral.
okay. Yeah, purposefully I cut out that other eye. Yeah, correct.
Yeah, then that anterior, the crescent-shaped anterior border is there in dermoid, but it is, I'm not sure. Actually, there is some.
Yeah, appendages will be there. If you do a radiological investigation, you can see the connection to the intracorneal fat in case of a fat prolapse, not so in dermalipoma. Dermalipoma will be present from the start. It can grow in the pubertal age group. That's a hamartoma. It's going to stay there. But this will be somewhere in the 50s and 60s because of the loose appendages, the fat tends to prolapse. This is a case of a fat prolapse. So how do you treat this case, ma'am?
Fat prolapse.
I had a similar case, but I thought it was a dermalipoma. Then I did some reading. I just wanted to, for a general understanding, how do you treat this case?
If the patient is symptomatic, you can leave it. Observe.
The patient came to me with both his fat prolapse. He had a very big cosmetic concern. And after doing the cataract, he told me to get this sorted. Yes, but
reduction of the fat. I don't know.
Yes, yeah, you just put an incision, whatever fat you are able to, reduce, you can reduce. What would be the best method to address this? Is you would use a cautery. You would just hold, you would crush the vessels with a mosquito and then mosquito or any tooth forceps, and then you would apply cautery. It will just melt off. And how much ever you can address, and then you can close up the conjunctival wound and call it a day. That's it. There'll be no capsule and all, so that's the whole thing of this. If it's a dermalipoma, you would want to get a CT done just to see if there is any posterior extension. Also, you want to see dumbbell dermoid. If it's a dumbbell dermoid, then you want to address it with an orbitotomy for complete excision. What do you see here? What is the thing? What ocular surface abnormality do you see in this case? And tell me two syndromes associated with this. Any takers?
Iris stromal defects.
It starts with the letter A.
It's a case of aniridia.
Perfect. Yes. Okay. Case of aniridia. What is the commonest surface issue that you see in this in case of aniridia?
In case of aniridia, there will be there is a limbal stem cell defect was there.
Deficiency. Yes. What will limbal stem cell deficiency cause?
There will be conjunctivalization of the cornea and cornea drying.
Corneal drying, no. Conjunctivalization, yes. Corneal drying with related to the function of the lacrimal gland, the mucin, and the the lipid formation. So there has nothing to do with limbal stem cell deficiency. In
And
chemical
also,
injuries, yes, dryness will be associated. Yes.
There is glaucoma risk in these patients.
Perfect. Yes. Yes. Glaucoma risk. Yes. And what are the syndromes associated in this scenario? And how would you manage this case? If you're doing cataract for this patient has cataract, what lens would you choose?
Morsher.
Morsher. No, it's okay. You can. There's a specific type of IOL for this case.
Aniridia.
IOL. Yes. Aniridia IOL. Yes. What are the syndromes associated with this? It starts with the letter W and G.
WAGR syndrome.
Yes. Can you elaborate on Vagar syndrome? What are the other additional disease pathologies associated with aniridia? A is for aniridia. W is for
Wilms
Wilms
tumor.
Wilms tumor.
Wilms tumor. Yes. Then
Genitourinary.
Growth genitourinary abnormal.
perfect.
Mental
And R for
retardation and
Mental
genitourinary
retardation.
abnormal.
yes. Yes. And cataract is with aniridia even. LSCD, you can do a slit procedure to maintain the surface after you kind of dissect the fibrotic tissue.
Sir,
And
what
yes,
kind of lens we can use in case of aniridia? I didn't get it. This
aniridia. There will be a central optic which is clear, and the rest all will be darkened out. It will actually be like more like a pinhole.
Iris.
It's to restrict the amount of light which is entering inside the eye.
Okay, thank you, sir.
It's called as aniridia. It is not foldable. It's a rigid lens. We have to do a sclerocorneal incision like SSCS to insert the eye. I've not done it. I've seen one. So yeah. What is the picture that 19 any takers picture seen here? This is after a procedure. And can you tell me some indications for this and some syndrome associated with it?
It is post-enucleation.
Not
and
enucleation.
Evisceration.
Evisceration, yes.
Evisceration. Okay.
Yes, outer coats are still present, no? So evisceration, yes. Okay.
Exposure
What
of
is a
orbital implant. Exposure
no?
of
This is after the procedure. They place a speculum, no? So just after the evisceration. So what is a what is the thing, the white thing that you're seeing here?
is clear.
Oh,
No, not
it's an
clear.
implant, sir. It's an implant.
Yes, yeah, yeah. It's an implant. Perfect. What is a common syndrome which you see after enucleation? And can you tell me some
Post-enucleation socket
features?
syndrome, sir.
Yes. Can you tell me the features of post-enucleation socket syndrome? That is very important. You should
Those-
hands down know it.
Yeah.
Most of the examiners will ask you. This is a very important thing. You should definitely know it. Can you tell me features?
The most important issue is, sir, the loss of intra-orbital volume.
Yes.
So it causes ptosis. It causes the enophthalmos.
Perfect.
A deep upper sulcus.
Perfect. Because there's no volume filling that. That's why you have deep upper sulcus. Yes. And something to do with the lower lid and something to do with the tilt of the processes. What tilt do you see in the processes, and what do you see with the lower lid?
Fornicial shortening.
No, there's a laxity of the lower lid, and when you place the processes, because of the volume deficit, what happens?
It tilts, the upper portion tilts backward.
Perfect. Yes. 23. Any takers? No. Oh yeah. Next.
I
thing.
can take, sir. I can take
it. Please.
It's, sir. It's a fracture of inferior orbital.
No. What is a radiological modality which is done here?
It's an axial CT, sir.
No. Are you sure it's
Coronal. It's the coronal
Yes.
view of the CT scan
Coronal
of orbit and brain.
Yes.
There is an inferior orbital wall fracture, which may be blowout fracture.
Perfect.
The most common causes is the sudden increase in intraorbital pressure.
Perfect.
Or
Which
maybe
area of the orbit, which area of the floor of the orbit will be most commonly, addressed, most commonly break during a fracture?
Inferior, sir.
Inferior, which part of the inferior?
Inferior medial.
Inferior
medial part of the inferior orbital wall.
Perfect. What are the indications where you need to address this fracture immediately? And what is the ideal time? If those indications are not there, what will be the ideal time to address this fracture?
Sir, the immediate surgery indication is a significant enophthalmos, which can be more than 2 millimeter.
Enophthalmos, okay.
Yes, asymptomatic diplopia which can affect the daily activity of the patient?
No, no.
If there is intractable oculocardiac reflex, which is not
Perfect. Yes,
controlled
very
by
correct. I had a patient. I had a patient actually. Yeah, no, I had a similar patient. This is just for my experience. I had a similar patient, a kid. There is also one more thing where you need to address it immediately.
White eye
It's called
Right.
fracture. Yeah, he had a kid. The kid had he had fluctuations in pulse rate. So immediately they had to operate it. Yes, anastomosis, trapdoor, and if there's a significant ocular cardiac reflex, what will be the ideal time to address this fracture? If
after 2 weeks.
After 2 weeks.
Perfect. How would you address the floor fracture? What approach would be preferred?
Transconjunctival.
It can be
Okay.
transconjunctival.
What material would you use to?
Teflon.
Okay, perfect. Yes. Next question. What is the thing that is seeing here? For what is this procedure usually done? And why gold?
This is upper lid gold implant.
Okay. What do you do it for?
In case of
Lid retraction.
exposure
Lag of thalmus.
Lag of
thalmus. Yes. Yes. Why gold?
It's inert.
Perfect. What other material is used apart from this?
Platinum. No.
Platinum. Titanium.
Titanium. Okay, yeah, titanium.
Platinum is used. Platinum is used.
Okay, so titanium. Okay, this is used to lag off, and yeah, that's it. I just want to show this because I had a similar case in the exam. So they asked me with the treatment protocol, and there are varying gold weights for varying degrees of lag off just to prevent exposure keratopathy. Okay, what is the picture that you see here? This is the external photography of the lid. What is it that you're seeing here? What is the diagnosis?
There is an ulcer.
It looks like molluscum lesion.
Molluscum, no. Molluscum, that will be raised centrally implicated.
But basal cell carcinoma, sir.
With rolled edges.
Yes, rolled edges, central crater with rolled edges. Okay, fine. So if for such a small ulcer, how would you manage the case? And what are the for lower lid, for 25 for a 25% of resection, 25 to 75, more than 75, what will be the procedures that you will do to recoup the lower lid anatomy?
If it is 25%, we can do the excision with a 4 millimeter normal margin and then direct closure of the lid.
Yes.
Then if it is more than that, means then you have to do the reconstruction procedures. Whether anterior lamellar or posterior lamellar, depending upon the involvement.
So if it is less than half,
like
reconstruction can be done with tensile semicircular flap.
Okay, that is for?
For between 1/3 and half of the lid loss. And if it is more than half, then we need to do grafting procedures.
Okay. For what lid would you do Hughes tarsoconjunctival, and what lid would you do cutler beard?
For lower lid, sir.
Okay.
Use for cutler beard for upper lid.
Yeah.
Perfect.
And Hughes for lower.
Hughes for lower lid.
Okay, if you do Hughes for lower lid, you have reconstructed the posterior lamella. What about the anterior lamella?
We can take a second graft, sir.
Perfect. Yes, full thickness. Perfect. Yes, that's it. Perfect. Tensile semicircular. You can just change the orientation. You can do that for both the upper and lower lid. Then you have median forehead flap for the upper lid. Just based upon the location, the reconstructive methods change. And yeah, I think that's it. We're done with 25. Thank you, everybody. It was really nice interactive session. I hope this was helpful. I tried to incorporate all the important questions as much as possible. Focus on the concepts, and that's if you are not left out with everything, the concepts is what is the thing that will save you. So all the questions asked are important. You can just go through all this topic, brush up whatever you can remember, and most of I've involved the questions which are asked in my exam also. So Hope it was helpful. Any other queries you can ask me.
Thank you, Dr. Pranessh.
Thank you, ma'am. Thank you. So kind of you, ma'am. Thank you very much.
Thank you, sir. Thank you.
Thank you so
Thank
very
you.
much.
Thank you. Thank you. Thank you.
Thank you so much.